consultant general surgeon and surgical oncologist in the Ojo Hospital in Lagos. I am the group head of the Department of Surgery and the clinical lead of Ojo Hospital. We welcome you to this presentation, which is a sort of enlightenment on the management of intracranial aneurysms.
The mic is muted.
Good morning, everybody. Sorry, my mic was muted. I'm Dr. Adebuje Adeniyi Sherif. I'm a consultant general surgeon and surgical oncologist, and I'm the group head of the Department of Surgery and the clinical lead of our Pituitary Hospital. I welcome all of you. Thanks for your time. We are here to enlighten ourselves about the management of intracranial aneurysms, which is the disease that needs expertise to manage, and there are many myths and surrounding that it's good for people to learn about. Welcome you once again, and we'll be having our neurosurgeons here to handle the topic. The Ojo and Dr Hospital is one of Nigeria's foremost private healthcare institutions. We have many hospitals which we have allocated specialties for. So we have hospital centers of excellence. We have our biggest hospital in Ikoyi, in 17B Bodilon Road, where we have our surgical center of excellence. So we have general surgery, orthopedics, pediatric surgery, neurosurgery, urology. So we handle all sorts of specialties there. That's where, and we also have our intensive care unit, which is very useful. We have referrals from different places for that. We also have a center of excellence for maternal and child health, pediatrics and obstetrics and gynecology in Ikeja and Awolowo Road. And we also have a cardiac center of excellence where we have cardiology, cardiac surgery, interventional cardiology in Ligali, Ayurveda in Victoria Island. Also, we have our outpatient departments in VI also, and we have also a wellness center there. So we appreciate your presence this morning, and we want to start with introducing our neurosurgeons, Dr. Ojo, who is a noted neurosurgeon of long-term experience, and we also have other neurosurgeon, Dr. Chiazor Onyia, who will be handling the topic. Dr. Ojo will be taking the presentations, and Dr. Chiazor will be in charge of the question and answer session. I will thank you all for listening, and we will cut to the chase and invite Dr. Ojo, our senior neurosurgeon, to start the presentation. Thank you very much for listening. Okay. So Dr. Ojo will do his presentation. Dr. Onyia too will present, then we'll handle the question and answer session. Thank you very much for your presence. We appreciate your time. Yeah.
Okay. I'm trying to get back on the system.
Okay.
Many people do you have online?
I want to share my slide. sharing, yes? Can you see my slides?
Stop sharing and start again, sir. Stop sharing. Start again. Don't admit, sir, so you don't interfere with
Okay.
it. Just go on this slide.
This is it.
I can see now.
Can you see my?
Yes, but you're muted. Very muted.
So I can limit this one, minimize, and okay, maybe this will just do. Okay.
You're muted, so you have to mute to start.
I want to keep this one somewhere that it won't distract me.
Please, so this right.
Okay.
You have to unmute before you start.
Okay. On mute. This is on mute.
No, no, that's the video.
Do I need to show my video?
Video.
All right. Okay. Good.
Good morning, ladies and gentlemen. My name is Ojo. I'm a consultant neurosurgeon. This morning I'll be talking about management of intracranial aneurysm. So like I mentioned earlier on, I'll be talking about intracranial aneurysm, especially the management. Just to talk a little bit about aneurysms. Aneurysms are abnormal outpouching of cerebral vessels. We have different vessels, the arteries and the vein, but this is more about the arteries. Once there's raised pressure within the vessel, it can bulge like balloon, as you see at the lower right-hand corner. We know from statistics that the aneurysms are more common in women, and it has three dimensions for the point or the sites of vessel bifurcation or the branching points. Usually where the flow would have gone if there was no form of branching. And the frequency is higher in the anterior circulation. If you remember the circle of Lewis, there's anterior circulation, there's posterior circulation. So we see more aneurysms in the anterior circulation. The definitive diagnosis of aneurysms has to be made by CTA, which is the computer tomography angiogram. And these will identify the ruptured aneurysm. In some cases, the aneurysms are not ruptured. The CTA will also identify. It's very important to note that aneurysm is a medical emergency and it's very life-threatening. Statistics show that 50% of patients will not get to medical, will not get to the hospital. They'll probably die before they get to the hospital. And another 30 may die regardless of what is done. So it's quite a big challenge to manage. Epidemiology of aneurysm shows that it affects 2% of the population and more than 10 to 22 per 100 people per year. And this varies in different regions. This also accounts for 5% of all strokes. So when you hear that somebody has a stroke, 5% of them may actually have
A ruptured aneurysm. What we also know that is it occurs slightly younger in the age group when we compare to stroke. So basically aneurysms will happen mostly between 40 to 50 years, but strokes may be more after 50 years. In our series, we realized that more of our patients had aneurysm between 40 to 56 years of age. Aneurysm is not rare in our environment. So years ago, we used to believe that we don't see aneurysms in Africa. And there have been different fora where this was mentioned, that no, we don't have aneurysms in Africa, it's more of the Caucasians. But to say that it is not seen in our region is not true. We do see, and in the past few years, we're beginning to see more due to different reasons, which I will talk about later. It's very important to note that very few of our patients will get to neurosurgery. For different reasons, the neurosurgical centers are fewer, Even where you have neurosurgery centers, not all of them will be able to manage aneurysm. It's important to know that with increasing awareness of ruptured aneurysm, subarachnoid hemorrhage, many people are now seeking for help. Very important to note too that it's quite expensive to manage aneurysm, and it's an emergency like I mentioned. If we want to put it in perspective, if you realize that 2% of patients will have aneurysms, and if you take it like that Lagos has 20 million populace, 2% of that will be like 400,000. I don't think we see up to that in Lagos. I don't think it's as common as in other places. Historically, like I mentioned, many people have said that we don't see in Africa. But in this paper, we realize that we may not see as much as other people do see in Asia, Japan, and Finland. But over the past few years, we're beginning to see more. The result of a particular study that was done by Professor Egbulem, that was when he was in the US, I guess, showed that aneurysm is definitely higher in the whites compared to blacks. In a ratio of 2.3 to 1, that's quite significant when you put everything together. And back to Nigeria, in the published documents, we'll see that this was about 2 years ago in the series in Ibadan. They say like 2 every year in the series that was quoted. Lagos about 15, Enugu about 8, Abuja about 7 per year. And when you compare this to Helsinki in Finland, where they see average of 142 aneurysms per year. But I must say, these were the people that presented for surgery, not people that had aneurysm. So the statistics is a bit unclear. And it's possible that the statistics are like that because large amount of cerebral aneurysm care in Africa goes unpublished, number one. Number two, many aneurysm cases are not being documented, or they are not seeking for help. So the different reasons why the statistics may be low. Anyway, back to aneurysm. 2 types basically: the fusiform, which is like a balloon that is being blown and everything is widening, like the one we see labeled as figure B, and the berry or circular, which is more common as the one we see in figure A. If you can see my cursor, this is the neck of the aneurysm, and this is the aneurysmal dilatation, unlike in the fusiform where everything just gets big globally. So there are different types, different sites rather, where we can see the aneurysm. But I won't bore us with this. Suffice to say that it is commoner in the anterior communicating artery than in the posterior communicating artery. In my series, I see more in the ACOM and less in the pericallosal aneurysm. So, how does patients with aneurysm present? One thing to note is when the aneurysm gets big enough, which is slightly relative, it will rupture. And when it ruptures, the blood that should be within the vessel will get into the brain tissue. And anything that shouldn't touch the brain, touching the brain will become an irritant. So blood actually is an irritant to the brain itself. And that is why patients with subarachnoid hemorrhage will present with headache and neck stiffness and maybe quite unwell. From raised intracranial pressure, they can start vomiting, and the level of consciousness may drop from mass effect and the hydrocephalus that the patients may have. When does the aneurysm rupture? This is quite important because when a patient comes with please, there is a background noise. Please, can you, there's somebody in IC or theater, the background noise is, yeah, please, can you mute your phone or your device? Anyway, so I'll continue. So when does the aneurysm rupture? We know that aneurysm will rupture at times of physical efforts like coughing, at toilet when one is bearing down. I've seen people lifting weights and the aneurysm ruptured, people struggling or fighting, and at sex. Basically, we should know that anything that will increase the Valsalva, that will increase intra-abdominal pressure like Valsalva maneuver, will lead to raised intravascular pressure, and that is when it ruptures. In a study by when does the aneurysm rupture? Aneurysm will rupture when there is raised intra-abdominal pressure, like in Valsalva maneuver, like coughing, at toilet. We've seen patients lifting heavy weight and it ruptures. One lady was singing soprano and it ruptured. Another one was arguing with her sister and it ruptured. Basically, once there's raised intra-abdominal pressure, Valsalva maneuver, there is a possibility of rupture. Why is this important? When you're taking the history and somebody tells you what he was doing when the headache started, then you can tie it up together and know. In a study done by Professor Nolly and Okese Obasikanon sometimes ago, they found out that 100% of men that died at sex had ruptured intracranial aneurysm. And if you look at the situation that may happen, many of them may not come to the hospital early until it becomes a catastrophe when they cannot be helped anymore. So basically, any Valsalva maneuver, anything that increases intra-abdominal pressure can lead to a rupture. So the natural history of aneurysm, the risk of rebleeding is quite high. In fact, within the first day, 4% of patients will rupture more than once. And as the day goes by, the chances are still there, even up to 50% within 6 months. What that tells is that if the aneurysm is not secured, it is a matter of time. It will bleed again and the patient will die. And mortality within the first few days is 10%, and in the first month is 50%. Very importantly so, the first bleed, many people may get away with it. The second bleed, fewer people may get away with it, but once it happens over and over, then the mortality will be 100%. The take-home message here is that once anybody has an aneurysm or it is suspected, surgery must be done as quickly as possible. We note that when patients don't get help, the mortality is quite high, especially in low and middle income countries, particularly in Nigeria. Once they are not helped, the mortality is abysmally high. Who may have aneurysm, or what are the factors? Uncontrolled hypertension. In 80% of our series, 80% of our cases had uncontrolled hypertension. Young men stopping antihypertensives themselves, or people who probably didn't know that they were hypertensive. Smoking will increase the risk of rupture. Alcohol use, in some cases too, is familiar. I've seen a mother, daughter having aneurysms at different points. Other associated risk factors, autosomal dominance like Ehlers-Danlos syndrome, and so on and so forth, may predispose to having an aneurysm. Basically, any issues with connective tissue is a concern for ruptured aneurysm. Other factors: age 50, female gender, cocaine use, and aphrodisiac use. Any other factors like this may increase the chances of somebody having aneurysm. The challenge of aneurysmal care in our region is late presentation. People probably don't know they had aneurysm, or the healthcare providers are not making the diagnosis. The low volume of cases also impair care, because the more the surgeon does, the better the outcome. How may they present? Unruptured aneurysm may present with mass effect or headache. And when you talk about the mass effect, like the lady on the right, this picture is here with permission. The aneurysm was pressing on the oculomotor nerve, and hence the ptosis you see on the left eye. And this was the same lady a few months after the surgery. So mass effect with the aneurysm sac pressing on nerves, and headache because the aneurysm is getting bigger. In ruptured cases, they will present with subarachnoid hemorrhage, severe headache. And I must say here that this headache is not the headache that somebody would not know that the time the headache started. It's usually severe thunderclap headache. Almost all of them will tell when it happened. When the vessel ruptures, there will be severe headache that anybody that had it will be able to tell. And because the blood will get into the subarachnoid space, the brain gets irritated, there will be photophobia, there will be neck stiffness, and so on and so forth. If the bleed is large enough, there will be intracerebral hemorrhage, which will kind of worsen the presentation by the mass effect. And in some other cases, there will be intraventricular hemorrhage, and these will worsen the prognosis. And many of them, maybe about 50, may die if they were not attended to on time. Diagnosis is usually by CT angiogram, but one can start with CT scan. CT scan will show subarachnoid hemorrhage, as you can see here. CT angiogram will show the aneurysm itself, and this is quite important for doctors to know, the neurosurgeon to know which of the vessels has bled, and that will guide management. In some cases, the magnetic resonance angiogram is helpful. In other cases, the clinical situation would suggest subarachnoid hemorrhage or ruptured aneurysm, but the imaging techniques may not pick the aneurysm. In such cases, one may need to do a lumbar puncture, and you see blood in the subarachnoid space. Non-contrast CT scan will show the layering of the bleed within the brain, and this is quite suggestive. And angiogram will show the vessel. As you can see, this is the circle of Willis, this is the right middle cerebral artery, and this is the aneurysm. In the definitive diagnosis is usually made with digital subtraction angiography, and here you can see the aneurysm. For the managing team, we should be able to reconstruct and be able to pick the aneurysm. This is the aneurysm here in the anterior communicating artery. When we know the patient has an aneurysm, we need to grade it. And the grading is for prognosis, and it's also to have an idea of what to do. So it's graded grade 1 to 5. 5 is worse, 1 is better, and then one can plan around that. How do we manage aneurysm? Prompt diagnosis is important. The earlier the diagnosis and care is started, the better for the patient. Appropriate imaging, reasonable set of equipment. At the minimum, there should be a microscope, which will help in magnification of the blood vessels and in illumination so that one can plan. Management of aneurysm is not a one-man show. It must include the neurologist, the neurosurgeon, the intensivist, the nursing care, as well as the physiotherapist. The steps to improve the care will be collaboration among all the carers, regional centers, and this is because the higher the volume, the better the outcome. Everybody will know what to do. The treatment options, medical, I will say at this point that medical treatment is not definitive. It's just to tidy up the patient until the aneurysm can be secured. Microneurosurgery includes clipping of the aneurysm or wrapping. I think it's more of the clipping and less of wrapping with advancing technology. The gold standard now in many centers outside the country is endovascular management of aneurysm, which includes coiling and stenting, and I'll talk a little bit about that later. So surgical options includes clipping, which entails occluding the vessel that has bled. And statistics have shown that when this is done properly and is done very quickly, as soon as the patient bleeds, the outcome is usually good. So basically, the definitive treatments are clipping and coiling. This is coiling. You can see the coil being packed into the aneurysm just to block off the vessel, the aneurysm part. This is the sac of the aneurysm, and this is the neck of the aneurysm. So the coil is being put there to isolate the sac. And clipping means you put a clip, like the regular clip we use when we put a cloth online, to close the neck of the aneurysm so that blood doesn't flow there anymore and the patient would not bleed. So this is a aneurysm sac that has been clipped. And the vascular, like I mentioned earlier on, is the preferred choice for many people because there's no incision, there's highly recovery. Complication is slightly less, but it's not without complication. And the complications include a high cost. It can rupture while it's being occluded, and the occlusion rate is slightly lower than the clipping rate. So this is what happens when you coil. I got this picture from Dr. Ahmed Nolowo, who is the interventional radiologist in Lagos, and he does coiling. So this is the coil being packed into the sac and in an attempt to secure the aneurysm, and it works very well. In some cases, it's difficult to clip and it's difficult to coil. In such cases, we use the flow diversion. We put the web there. This has secured the aneurysm, so blood flows through this place, and this sac is isolated. In other cases, we may need to bypass the aneurysm completely by doing an anastomosis. The surgical option as of now is the current mainstay of treatment in Nigeria as well as in other low and middle income countries. And to do this effectively, you need a microscope for illumination and magnification, and all this will ensure there is great outcome. The principle of aneurysmal surgery involves the neurosurgeon knowing exactly what to do. Aneurysmal surgery is not brain surgery. We have to be in the subarachnoid space, and this has to be done without damaging the brain or making incursions into the brain tissue. And these are what is necessary: positioning, microscope, and being very careful of the perforator. But very, very important factor is for the surgeon to acquire skill so that the outcome will be good. When the brain is open, it looks tense like this. What you see here is subarachnoid hemorrhage, blood in the subarachnoid space. And the brain is always very tense at that time. It's reacting to the blood because the blood there is an irritant. And the key there is to be able to open a relaxed brain, as you can see here. At this point, we open the Savian fissure, and when you're done with the Savian fissure, you see the blood vessel, the artery, and we can follow the artery until we get to the aneurysm. Most people will not retract, but it may be important to retract the brain a little so that we get to where the aneurysm is. So in this case, you see the blood vessel there. To secure the aneurysm, we need a proximal control. We need to stop the blood flow to the part of the aneurysm. It's like you trying to secure a blown up oil well. You need to close the valve at some point, and when you close the valve, then you can approach the oil well. So here, you put the clip on the major blood vessel. It will stop the blood flow to the area of the aneurysm. In this case, the aneurysm is at the posterior communicating artery. So we put a clip on the internal carotid artery, and we can access the aneurysm. So you see carefully there, this is the clip that has been placed to secure the aneurysm. Then we'll take off the clip on the proximal control. In some cases, the bleed is massive, including intraventricular hemorrhage. So here, this is the intracerebral hemorrhage from an aneurysm. The same thing I showed at the earlier slide. We open the Savian fissure, get to the intracerebral space, intracerebral hemorrhage, get out the bleed, and that can actually lead directly to where the aneurysm is. The advantage of this is you clip the aneurysm as well as taking out the hematoma, which is giving the mass effect. So this is the aneurysm, and this is the point we try to clip the aneurysm. This is the neck of the aneurysm, and that is the clip being applied to the neck of the aneurysm, and that will solve the problem once and for all. So what many people fear is intraoperative rupture of the aneurysm. In many instances, this will worsen the prognosis, especially if the surgeon is not able to secure the bleed or the ruptured aneurysm. Patient will just either it's a grenade or the brain will infarct, and that will lead to the demise of the patient. It's a major complication of clipping the aneurysm. But if in an experienced hand, it can be appropriately managed. Just as you can see here, it has bled and it is being secured properly. And this is what it looks at the final stage of the surgery. It looks very calm and quiet. Many times also, we're not sure of the adequacy of clipping or the patency of the adjacent vessels. In other clients, once you clip the aneurysm, you do intraoperative angiography to see that the vessels are still patent. But there is another way we can do that. In my series, I use intraoperative Doppler to ensure that the vessels are still patent. Because if the aneurysm is clipped and I inadvertently clipped another vessel, the patient would suffer massive stroke. The factors affecting care are one, the skill of the surgeon, and this can improve with experience. The equipment that is available, the microscope, the scissors, the different types of clips. Money is quite important because all this will cost a lot. And very importantly is the supporting system, the ICU and the critical care specialists. If a center lacks any of these, the outcome may not be as good as a center that has it all. My slide is not moving. So this slide shows that the more we do, the better the outcome. So when I first started, not very good, but with increasing volume, the outcome looks better. It's freezing. So what is the future in Nigeria? I think in the future there will be many more centers that can coil aneurysm. Right now in Lagos, I think there's only one place, but I think with time, more people will be able to coil. Also, it's freezing. Excuse me. Anyway, I'll just round up very soon. Okay. So what are the complications of aneurysmal surgery or aneurysmal care? One is vasospasm, and this is the most common, and it can be a disaster if not well treated. In 48 to 72% of cases, it can happen within 48 to 72 hours of surgery. Hydrocephalus may develop. Many of them may have psychological issues, depression, frontal lobe, and some may pass. When do we secure aneurysm? And this is very important because time is of essence. The best time to secure an aneurysm is within 24 to 48 hours of bleed. The next time is as soon as the patient gets to the doctor. Delaying aneurysmal care is always a disaster because of the risk of rebleed. And if you put it in perspective, many of our patients don't come early, and they come when the aneurysm is particularly has taken enough toll on their system. There's been a lot of debate on early versus late surgery, but late surgery doesn't have any significant advantage over early surgery. I think the earlier the surgery is done, the better for the patient. And these slides is that the internet problem? Oh, okay. One moment. Well, anyway, I'm actually done. I'm almost done. Yeah. You can see my slides again. Okay. Can you see my slide? Okay, just a moment, I'll sort it out. I can use my internet if yours is a problem. We should switch internet. Dr. Onyia, I think we'll use my internet for you. There. What do you think may be the reason? It's completely frozen. Okay. Let's escape this one. Okay.
So I think you have to stop your teams and start it over.
Okay.
Yes, you will have to take the video off.
This hasn't happened before, sir. Should I put it off and on? I think it's my team. I think it's my team that froze. Everything.
Everything's frozen.
Yes.
So if you can start your teams over.
My sister.
You're using the browser, right?
Yes. In our region, we struggle to get the patient to theater early, but we know that the earlier the surgery is done, the better. In our series, we realize that most of the patients are actually not very good at presentation. The grading usually poor. So just a case to illustrate the point. Here was a 37-year-old lady with severe headache, a neck stiffness of about 2 days before she presented. She's a known hypertensive for 5 years. Like I mentioned earlier on, many of them have uncontrolled hypertension. This lady deteriorated 72 hours after the diagnosis was made. And on the day she was to go for surgery, she suddenly dropped GCS to 3, the poorest anybody could guess. She already had an isochoria, right pupils was 5 millimeter and unreactive. We took her to theater, and she actually did well. Within 2 days after the surgery, she started to improve. It is quite clear that the earlier the surgery is done, the better for prognosis, and this has been documented in the literature. This was another 14-year-old lady who had bled a few times before she was referred. And shortly before her surgery too, she almost arrested, and she was taken to theater. She had a large MCA aneurysm with intracerebral hematoma. She was in ICU for about 10 days, developed hydrocephalus and was shunted. She was in ICU for like 3 weeks before she was discharged, and this was the same lady months after, fully intact. So basically in Nigeria, there are very few centers where aneurysm can be cleared. Of course, this is Oyo State, this is Abuja, this is Owerri, this is Lagos. I'm not sure where this is, maybe Akwa Ibom, and this is Kano. We really need more centers in the country to achieve adequate coverage for our patients. Remember, the later they present, the worse the prognosis for the patient. So my recommendations would be: 1, the government should try to have neurosurgical regional centers and timely intervention when it is possible. Centers should have neurovascular group that has all the equipment ready for surgery or for care. There should be increasing awareness. We should be able to pick patients with subarachnoid hemorrhage, and surgeons should train and retrain. And this will drive care. The more volume the surgeon has access to, the better the skill, and also this will enhance training. So health insurance will do this, will ensure that care is available for anybody and everybody that has subarachnoid hemorrhage. Thank you very much. Okay. Should we take questions? Okay. We'll take questions after the second presentation.
All right, good afternoon, everyone. Good morning. Good afternoon, everyone. So we thank you so much for your time. We'll be having all right, thank you very much. Good afternoon, everyone. So we'll be having Dr. Onyia, Chiazor, presenting for local neurosurgeon. So give us some few minutes to set him up while he kicks off the presentation. Thank you so much. So also we'll have the questions and answer after the second presentation. Thank you so much.
Good afternoon, everyone. Quickly, without wasting further time, I'll be speaking on microscopic pituitary surgery.
We all know what the pituitary gland is. That's the gland that is referred to as a master gland, located at the base of the brain, and that is related to the cellular tussica. As you can see in this picture, if one draws a straight line from the root of the nose inwards, and you draw another line from the ear, the opening of the ear, where both of them would meet, is a rough estimate of the location where this gland is found. And as you can see, the middle picture is made up of an anterior lobe and a smaller posterior lobe, and a tiny middle portion called the pars intermedia. So quickly thank you. Brief background of the pituitary gland. It's a structure in the brain that has undergone evolution over time in terms of the problems that are peculiar to it, as well as the various treatment paradigms various treatment paradigms over time. As I said earlier on, it's referred to as master gland, particularly because it controls majority of the hormonal functions, and of course metabolic functions too in the body. And just for a historical perspective, treatment of this problem has been on for more than 100 years. As far back as 1889, the first surgeon who attempted to operate on it, by name Victor Horsley, did it through the transcranial approach. Later on, about approximately 5 to 10 years later, a German surgeon, Mr. Schloffer, tried to operate it through the transcranial approach, which is actually the main focus of this discussion, because that's the approach that is more favored in current day practice of surgical treatment of tumors of the pituitary gland, and on and on and on. And Harvey Cushing, as well as Jules Hardy, and several other notable surgeons have made landmark advances in surgical treatment of this problem. By and large, as time has, over time, the treatment paradigm that is most favored is microscopic and endoscopic treatment, because those are just what one may refer to as some kind of minimal access surgical treatment of pituitary gland compared to open surgery. It's not moving. It's not moving. Okay, thank you. So this is just a picture showing some of the surgeons whom I've mentioned, particularly Jules Hardy, who popularized the microscopic treatment for pituitary gland tumor, which I'll be focusing this discussion more on. This picture just shows us an anatomy, just picture showing us an anatomy of the pituitary gland. Like I mentioned, it has the anterior lobe, smaller posterior lobe, and that's supplied by a portal system of vessels, okay, like kind of meshwork of vessels, which are formed from the hypophyseal artery. Then in terms of its function, it's the master gland, like I mentioned, and the way of function that it works by feedback mechanism, by working on most of the glands in the body, okay, from the adrenal glands to the gonads, both in males and females, the mammary gland, and so on. So it controls most of the functions throughout the body, particularly hormonal functions that have to do with reproduction by way of feedback mechanism. And of very important note is the anatomic relations of the pituitary gland, which is one of the key aspects of knowledge, of practice, of practicing pituitary surgery. One needs to be very conversant of the anatomy of that region. The key structures to take note of there is the internal carotid artery. That is close to where the arterial circle of Willis is located. Then it's also closely related to the optic chiasma, which is the junction of the two optic nerves around that point. And of course, very important is the cavernous sinus, which is a meshwork of venous structures on either side of the cellular tussica. Then for the investigations of importance, because, like I mentioned, it's the master gland controlling most of the endocrine functions in the body. Most of the investigations, okay, are endocrine related, hormonal functions, particularly the hormones that come from the anterior pituitary gland. That's talking about the thyroid function hormones, T3, T4, and then thyroid stimulating hormone, as well as prolactin and cortisol. And these are very important. The last two, they are very important because apart from being the hormones that are implicated in most of the hormonal problems the patients present with, they also form the basis of monitoring the patient even after surgery, and to see whether the patient is improving or even if there's a recurrence. Then that aside, the other important investigation of importance is ophthalmic evaluation. Like I mentioned, one of the close relations in that region where the pituitary gland is located is optic chiasma. And for that reason, most of them tend to present with visual defect or deficits as a time when they already have the problem that are coming to see us in the clinic. And so for that reason, one needs to get an ophthalmic evaluation. First of all, to get a baseline, to know what the problem is at the time when the patient is being treated. And then that baseline can be used to follow up the patient and see how the patient is progressing. And also it's important to do so in case there are issues with vision somewhere along the line. So one can know whether the vision was something that happened as a result of the surgery or some other problem. So it's important for the reason of monitoring after surgery. Now, in terms of the clinical presentation, there are various ways this problem could present, but generally they could present with the hormonal manifestation, ranging from galactorrhea, particularly in females. When a female is not supposed to be lactating, all of a sudden she's having breast milk coming, to problems with infertility, impotence, and of course, because of pressure effect on the optic chiasma, visual impairments of various sorts, commonly visual field problems, and to an extent, they may also have blurring of vision due to papilledema and hydrocephalus. Hydrocephalus, that's obstruction due to CSF outflow. Reason being that the pressure for mass pressure effect of the tumor, in cases where the tumor is large enough, on the third ventricle, which is one of the superior structures, superiorly related rather, to the gland, it may be compressed, and that may impair CSF outflow from the third ventricle, and generally the CSF may accumulate and give the patient hydrocephalus. Sorry. Okay. Then that aside, there's a condition that we refer to as pituitary apoplexy, which is one of the ways of which the problem could also present. In this case, it's a situation when there's a sudden bleed into the gland, and then the patient suddenly deteriorates. Okay, and the suddenness can even be bad enough to cause a sudden death, or just impairment of consciousness or impairment of vision. And last but not the least, it's not on this slide. It's what we refer to as incidental finding. Okay, in which case a patient may just go to get an evaluation for some other problem entirely, and then in the course of doing a scan, notice that he or she has a pituitary gland tumor. So by and large, those are the various clinical manifestations or presentations of this problem. Then in terms of its classification, it will grade it according to the size, in which case you may have a microadenoma or macroadenoma. Okay, and then in some cases, a giant pituitary adenoma. Majority of cases, the size ranges from 10 millimeters to 40 millimeters. Once it's more than 40 millimeters, it's already, in its widest diameter, it's already a giant pituitary macroadenoma. So these are some pictures just to show us how some of these tumors could look like. The one on the upper two to my right, to the right side of the screen, shows just the pituitary adenoma, what it looks like, just in this region, just below the sphenoid sinus. The one lower down to the left is much bigger, and that falls into the category I may refer to as a giant adenoma, pituitary adenoma. Some of the things that I didn't mention in the last slide, that in in some cases, or what this particular slide is showing pituitary apoplexy. This apoplexy, like I tried mentioning in the last slide, might actually be a bit more chronic than acute. Majority of the time is an acute problem, but occasionally some of those symptoms may progress not so rapidly, in which case we may refer them to them as being chronic. One of the things, or one of the symptoms we can present with is drop in all the level of the pituitary hormones, referred to as pan-hypopituitarism. I already mentioned about loss of consciousness. Complete blindness, again, is another manifestation of this problem. And then in the late phase, because it's a problem with bleeding, sudden massive bleeding into the tumor, it could make the tumor to become liquefied, okay? In which case, most of the time, what we aim to do at that stage is just to quickly decompress. And decompression, most of the time, if it's done early enough, can allow the patient some significant amount of recovery. In terms of its classification, there are various classifications, but for clinical practice and for us as surgeons, the classification that is most important because of prognosis and also in terms of allowing the surgeon to make a plan and know what to do, depending on the kind of tumor or the grade of the tumor rather, is the grading that has to do with the extent of involvement of vessels, vascular involvement. I was talking about the internal carotid artery, like I mentioned in the anatomy slide on anatomy, ranging from grade 0, when it's just on the medial margin, getting to the medial margin of the intracavernous portion of the internal carotid artery, as opposed to grade 3 and grade 4, when it has gone all the way to the lateral margin. It has, as per the tumor has encased the entire vessel all the way to the lateral margin, okay, beyond the cavernous sinus. And by the time it gets to grade 3 and grade 4, it already shows that the cavernous sinus is invaded. And this is very important because it's going to give the patient, the surgeon rather, a guide on what to do, the plans that need to be made to take care of that and avoid injury to the internal carotid artery. Then of importance, apart from the vascular involvement, which is more like lateral extension of the tumor, is also what we refer to as the suprastellar extension, when the tumor grows upwards, in which case it grows upwards, and the two structures that are of importance in this case includes the third ventricle and even more importantly the hypothalamus, which is a very key structure in the brain, controlling most of the involuntary functions in the body. So when there's suprastellar extension, it's very important for the surgeon to consider that in the surgical plan to make sure that there's no hypothalamic injury. Then in terms of the preoperative workup, first on the list is always neuroimaging, at least to confirm the tumor, know the extent of the tumor, know the extent of involvement of the surrounding key structures, and like I mentioned, that would also help one to make a plan, a thorough surgical plan. Then besides that, it's important to get a hormonal assay, just like the neurophthalmic evaluation to know the state of the visual impairment before surgery. It's the same thing too. Regarding the hormonal assessment, one needs to know and document the baseline hormonal function before surgery because apart from the need to follow up, there may be medical legal issues. Sorry. Okay. Sorry for the interruption. There's a problem with the slide showing.
It has gone back to your internet.
Okay, that's internet.
Yes.
Is it automatic? I thought when you...
It has gone back to your internet.
It's still not. Okay.
So it went to your
Even this one is not showing again.
Let's remove this one first.
Okay. artery and the cavernous sinus. And then I also spoke about, it's not moving. Okay, the mouse. Oh. Okay, yes, thank you. About the supracellular extension, in which case it extends upwards to the third ventricle above as well as the hypothalamus. Where do I click? If I want to move.
Some people are talking.
Okay, I can use this now. Very good, fantastic. Great. Okay, thank you very much. So I'll quickly go through the remaining slides so we can take our questions and any other comments or clarifications. Then I was talking about the preoperative workup. Topmost on the list is the neuroimaging. That's talking about MRI scan or CT scan of the brain, preferably MRI, because it better delineates the tissues and the tumor and give us a better picture of what is happening there to help us plan better. And that aside, it's important to also do a hormonal assay. In fact, it should be done preoperatively. And the reason is that it helps us to get a baseline to monitor the patient after the surgery as per follow-up, as well as for medico-legal issues, in case there's any problem regarding hormonal function, probably months or years down the line. And that aside, there may also be need to do chemistry of the patient. I was talking about biochemical tests, as well as hematological tests, as to prepare the patient for the surgery. And also to know if there are any parameters that may need to be optimized before the surgery to ensure the best of outcomes. Then, of course, it's important to take informed consent. Being a surgical treatment, the patient needs to be aware of what the plan is and what the surgeon hopes to achieve and other possibilities in terms of complications. And of course, they may need to use some drugs before the surgery, particularly steroids, which may help to minimize the effect of the tumor on the surrounding brain. And very important, last but not the least, is the need to review the anatomy as not just once, but before the surgery, to study it thoroughly and as many times as possible, to be very certain of the problem and to be very clear about the surgical plan. Now, in terms of the indication for surgery, there are clear indications for pituitary surgery, pituitary tumor surgery. The first on the list here is the visual symptoms. Okay, like I mentioned, some patients may have the problem as an incidental finding. Okay, so that might not be an indication for surgery, but by the time the patient is coming down with visual field deficits and other visual manifestations, that's a clear indication for surgery. And of course, the need to treat the patient in case of hormonal issues, problems like galactorrhea and infertility, problems with the menstrual periods in female patients, and so on and so forth. Those are also clear indications why the patient will need surgical treatment to remove the tumor. And of course, headache, which is one of the symptoms, okay, particularly in pituitary apoplexy, like I've already discussed in one of the previous slides. The goals of surgery, first is to target the tumor mass. It's a space-occupying lesion. And by way of being a space-occupying lesion, it's going to give pressure symptoms. So reducing the tumor mass as much as possible is one of the key goals. And of course, because of the hormonal importance, being the master gland controlling hormonal functions in the body, it's important to normalize hormonal function and preserve its function generally. Then besides, apart from that, the need to remove recurrence as much as possible, in which case one will be targeting complete elimination of the tumor, and not just partial or subtotal resection, but gross total removal of the tumor mass. In terms of preparation for the surgery, talking about the nitty-gritty now of the surgical treatment, apart from all the things that has been done in terms of preoperative planning, now at the time of surgery, positioning is very key. It's very important to make sure that the patient is well positioned. You may have the best of skill, the best of equipment, but if the position is not right, it's going to be a struggle carrying out that surgery successfully. So positioning is very important. And of course, because of the fact that it's a very delicate part of the brain, like I mentioned, it's transsphenoidal. I will show you some pictures. Transsphenoidal just means going through the nose, okay, to get access to the tumor. For that reason, you need very good magnification, and that's the reason why microscope is mentioned here as one of the key elements or one of the key needs in preparing for the surgery. And because of tendency of that part of the skull base, okay, to bleed, because of its high vascularity supplied by many vessels, particularly the sphenopalatine artery that supplies the nasal mucosa and the sphenoid sinus and its mucosa as well. It's important to secure meniscus, and to achieve that, we use adrenaline-soaked gauze of this concentration, 1 in 100,000. It not only helps us to secure hemostasis, but also to decongest, that area. Even after the surgery, the patient will not have problems with congestion, just like it happens with people that have sinusitis. And then, in order to achieve as much as possible asepsis, we use betadine for our skin preparation and, of course, draping too. Now, talking about pituitary surgery, generally, they can be broadly classified into the transsphenoidal approach. That's when you go through the nose, or just the transcranial approach, which was what many surgeons started with many years ago. Okay, but for the focus of this discussion, we'll be talking about the transsphenoidal approach. The key things to consider when planning the approach is, first of all, the tumor size. Most of the tumors that fall into the category of just being adenoma, or the smaller ones, the microadenomas, like I tried describing in one of the previous slides, fall into the category that can be treated, successfully and without struggle through the transsphenoidal route. Unlike the very huge tumors that may be too big to take out through that small, route, in which case you have to go transcranial, going through the cranium, make a big wound on the head and open the skull bone to get access to the tumor. Then, of course, is the level of scale of the operating surgeon. The surgeon needs to be skilled, so it's always better to go for the approach that one knows he has enough skill with. And of course, to consider the available facilities, one needs to particularly good magnification and excellent lighting too. Those are very two important needs. Then, that aside, planning for the surgery, I mentioned that one needs to study the scan thoroughly. One of the things that we study in the scan, as you can see in this picture, is the structure called the sphenoid sinus, where my cursor is. That's the sinus that is just beneath the sella turcica, where the tumor is normally located. Okay, so one needs to know how well pneumatized it is. Just like most of all the other sinuses within the skull bone, the pneumatization is of particular importance to us in this surgery, because it guides one on how the trajectory of the tumor should go, as well as other things that need to be considered, just for safe approach to get to the tumor as safely as possible without any damage or compromise to the surrounding structures. Like I'll talk about in the later slides, talking about complication. And very important is also to plan for the carotid artery. I already mentioned about the NOPS grading, which helps us with that, to know which category each tumor falls into. So one plans carefully, because carotid artery injury is disastrous. Most of the time, the patient will not make it if it ever happens. Luckily, it rarely happens when the surgery is thoroughly planned for, and with the right approach, and with correct use too of some devices like intraoperative Doppler, like I was talking about. That shouldn't happen. But that's the reason why we also consider it as one of our key factors in our planning. And then one needs to have blood, because apart from the carotid artery, the cavernous sinus too are there by the sides, very close to the tumor, and they could bleed significantly enough for the patient to need blood replacement as well, blood transfusion. And of course, this surgery must be carried out in a center where there's availability for intensive care. There must be intensive care unit. It's never the best to carry out pituitary surgery, in fact, any brain surgery, in any facility that doesn't have intensive care. I already spoke about the microscope. This is a very important instrument. In fact, from the name of the approach I'm discussing, microscopic, transsphenoidal surgery, you need a microscope. The microscope, there are many standard microscopes, but here at the Wilson Lagoon hospitals is the Kenevo 900, which is like the topmost among the grades of available microscopes currently. The idea is to get the best of magnification, and it helps one to maneuver to get good view, not just view, but three-dimensional view of the tumor. And that's very important too, for safe approach to the tumor without compromise to the surrounding structures. And also the microscope should have the proper focal length to enable the surgeon get good precision in terms of view of the tumor. Then I spoke about the sphenoid sinus, which is the reason why we study its pneumatization, because there are various forms that this sinus could take. If it's well pneumatized, the more pneumatized it is, the better. Okay. Now, one of the key factors for safe surgery through this route is clear identification of the sphenoid sinus. They shouldn't be ambiguous at all. And to achieve this in the past, in fact, over years, it has undergone, the methods of identifying the sinus has slowly evolved over time. In the past, like as long as 40 years ago, what was in vogue was X-ray. That's before the advent of CT scan, MRI, neuronavigation in form of brain lab, like I've mentioned in this slide. X-ray used to be the gold standard then. Then later on, X-ray was phased out with the advent of more modern devices and equipment like neuronavigation, which is what you can see at the bottom slide here. You can see a picture showing the surgical field where I put my cursor, and then you can see some other pictures. What neuronavigation does in essence, that's what this picture is meant to demonstrate, is that it just gives the surgeon exact precision of where he is at any moment in time, at any point in time. And the idea is just to help him get to the sphenoid sinus with as much precision as possible without any errors. But we know neuronavigation is not something that may be available everywhere. So the other methods that people have used. Otherwise, currently now, one of the methods being used to identify the sphenoid sinus is an intraoperative CT scan, three-dimensional CT scan. It's available in some centers, probably not in Nigeria yet. We're hoping to get there. But by and large, those are the methods. Okay? So, but in our own case here at Wilson Lagoon Hospitals, apart from the CM, which is the form of X-ray that is available, the microscope, first of all, studying the scan carefully most of the time. If you study the scan very well, and you have a very good microscope with very excellent lighting, identifying the sphenoid sinus shouldn't be a problem. We'll talk about these methods, in extreme cases where it may be difficult, particularly in cases where it's like a reduced surgery or the tumor has destroyed the surrounding structures and anatomic delineation is no longer clear enough for the surgeon, in which case you may need to fall back to some of these options on this slide. Then talking about the landmarks, the important landmarks, okay, that will also help the surgeon. And in this case, what we normally use is the middle turbinates, okay, or the middle turbinates. And as you know, there's the inferior turbinate, the middle turbinate, the superior turbinate, and all of them have their ostium. The middle turbinate is the key structure that we use because it's just opposite the point where the key structures that form the midline, okay, the midline structures that leads us to the sphenoid sinus is located. So once one, begins to, once you put in your speculum, the first thing you want to do is to identify the middle turbinates. I already mentioned the need for the CM and neuronavigation in peculiar cases where the anatomy may be distorted. This picture is just to show us the basic landmarks. Okay, the picture on top shows us the sphenoid sinus and the arrow, the sella turcica, which is where the tumor is located, okay, is superiorly located to the sphenoid sinus. Okay, and below, if you follow that point a little more inferiorly, get to the clivus, which I'll be talking about in one of the slides. You don't want to go to the clivus because it will lead you elsewhere and cause more problems. So the idea is to be very clear with the landmarks. The key thing to note in this slide is the middle turbinate. If you notice in the picture, the lower picture, which is an MRI, sagittal view of a patient's MRI scan, a patient with pituitary tumor, you can see the green arrow just showing us the trajectory. Now, this trajectory is pointing to the wrong place. It's pointing towards the clivus, which you don't want. You want it to go straight up this way, straight to the sinus, okay? So if you obey the rule of following the landmarks carefully, Okay, particularly when the anatomy is still clear enough. One shouldn't fall into the problem of going to inferior line and going to the clivus, or going to upward and going to the ethmoid sinuses. That will cause another problem. That's talking about CSF leak, like I'll talk in one of the slides. Now, this picture shows us the view that one would get if you follow the landmarks carefully, and then you have, after coagulating the nasal mucosa and detaching it. This is what the appearance of the sphenoid, the wall of the sphenoid sinus will look like. Where the white squares are located those are the sphenoid ostia. The sphenoid ostium on the left side, the one on the right side, and the arrows I drew are some landmarks that we've discovered over time. In fact, this has been published. We've published this, as you can see, at the lower part of the screen in the World Neurosurgery. Over time, we've discovered that apart from the sphenoid ostium, like I mentioned, as depicted by the white squares, small white squares, we discovered that that this area that is marked, okay, is like a junction between the point where the wall, the inferior part of the wall of the sphenoid sinus coming upwards from the area of the clivus, and then it's the superior part coming below from the area of the sphenoid sinus. There's a point where they join and they form an imaginary line. We've discovered that this is consistent in all the cases we have operated, and it has been published. It's a very good landmark. And if you notice in this next picture, what this landmark does is that it just gives one a safe area. You can see the shaded area is what that landmark helps us to delineate. Now, this shaded area is an area that if one removes what we call medial anterior sphenoidotomy. Anterior sphenoidotomy is just the anatomic removal of the floor of the sphenoid sinus to get to the sella tossica, where the tumor is located. Where the tumor is located. Now, to get there safely, if one follows those demarcations, the two white squares, that's talking about the sphenoid sinuses, and then delineate this line, the point where all of them join, I draw a line that connects all of them, it will form this shape, and one can safely do anterior sphenoidotomy, so removal of the anterior wall of the sphenoid sinus to get access to the sella tossica, okay, during the transsphenoidal removal of the tumor without compromising the surrounding structures. And if one goes below this, this is the clivus, which is the area that leads to the brainstem at the back with the basilar artery. You don't want to go to the brainstem. That's disaster. The basilar artery is also a very major artery supplying the brain. You also don't want to go there. That also spells disaster if it happens. So the idea of these landmarks and these shaded areas I'm marking out is just for safe access during the anterior sphenoidotomy aspect of the surgery, removing the anterior sphenoid sinus. So that's the reason for this slide, is this still demonstrating the same thing. Okay. So now, once we're done this, so this is supposed to be a video, I think, but it may not, it's not playing. So this is just, okay, I think it's playing slowly. So this is a short video showing what it looks like once the anterior sphenoidotomy is done. So as you can see, this is the magnified view of what I just showed us in the couple of slides that I just discussed. That's talking about the anterior wall of the sphenoid sinus. You can see it's a very narrow corridor, but with the microscope, everything is blown up and it looks big and clearer to the surgeon. The idea is to go safely through the wall of, you see, we're going to move the wall of the sphenoid sinus. That's that sinus, the airspace, anterior to the sella tossica where the tumor is located. So that's what this slide is. Sorry, because of time, I won't be able to play the entire video. I'll go on to the next slide. Sorry. Okay. All right. So I'll talk about this slide quickly. Now, this slide is just to show us the limits of the sphenoid. You can see now in this slide, this video is showing us the anterosphenoidotomy. We're removing the wall of the sphenoid sinus. That same picture, we're doing the sphenoidotomy now. So we've removed it just on the left, to the left of the screen, about to move it to the right. This picture on top in the scan, if you just transfer your focus to the picture on the top right hand of this slide, you see that there's a mark. We marked what we call the Y junction. Okay, that's the junction where the sphenoid sinus, the wall of the pituitary gland, marked in yellow. The wall of the sellar tussock, marked in yellow, and then the wall of the sphenoid sinus itself, okay, which we are removing in this video, marked in red. Where the two of them join, if you notice, it's like it continues downwards, okay, as a blue limb for the Y. The idea is that you don't want to go beyond the junction where the two of them join. That's the red line delineating the wall of the sphenoid sinus, and the yellow line delineating the floor of the sellar tussock. The idea is that you don't want to go beyond that, and that's the reason why we use the probe. That's one of the things that we probe. Once you keep on doing doing the anterosphenoidotomy as we're doing in this video, and you get to the point, the Y junction, you would know once you probe it that you've gotten to that point, and you must not go beyond that level. Otherwise, the next thing is that you just go into the clivus. And once one enters the clivus, the structures there, the brainstem, that's talking about the pons and basilar artery, they're already facing the surgeon, and then the risk of injury happening to them will be high. You don't want that to happen. So that's the reason behind our concept of Y junction. It has been helpful as a landmark in carrying out this surgery here at Chiazor Lagoon hospitals. It's part of the thing that we mentioned in that publication too. So this video is just talking about the same lines I discussed in the previous video, okay? Junctional point from the area above and the area below. Once you start removing from that point and you get to the Y junction, you don't want to go beyond that. That's the end of the sphenoidotomy. Once you get to the Y junction, you stop the sphenoidotomy and go on to the next phase, which is to remove the tumor now through the floor of the sellar tussock. Now, I'm talking about the tumor resection, okay? You want to achieve as much as possible a complete resection. So one of the things that we normally plan for when we're doing this surgery is to make a plan for how that would happen. If it's not going to happen, we'll have a few things we'll do to ensure that it happens. One of them, as you can see here, is the Valsalva maneuver, which an anesthetist does for us, so that any tumor that might not be evident to the surgeon after the removal of the initial one that is evident, at least under clear vision, under the microscope. This maneuver normally would make whatever remnants or tumor hidden in the corners of the folds of the dura to descend. Something else that could also help is a lumbar drain. And then it's important to know that the more suckable the tumor is, the better. And luckily, majority of the tumor in up to 80% of cases, they're suckable, unlike a few ones that may become fibrous, particularly the recurrent ones. Now, talking about dissecting the tumor, I mentioned about the probe, okay? One of the other things that the probe helps us to do, together with the curettes, is to help us take out the tumor. Because the problem is that because the tumor tends to grow sideways and upwards, it stretches the dura. So by the time the patient stretches the dura, so by the time the tumor is coming down, sometimes in inexperienced hands, much of the tumor in the core of the tumor in the middle may come down, but the ones at the corners, particularly the extensive ones growing laterally to the sides rather, those ones may become trapped if the one in the middle descends too quickly. So to prevent this, we use the probe as well as the curettes to make sure that those ones by the corners, they come down too, and they don't get trapped. And besides that, we also utilize scissors. We utilize sharp dissection as much as possible. It helps us to keep the anatomic planes well delineated so that we know when you're getting to which level, what level, and the next level. So that way the surgeon will not be confused. And of importance is the posterior pituitary gland. Most of the time, because of the way the tumor tends to grow, it tends to plaster the posterior part of the pituitary gland posteriorly. So when taking out the tumor, it's important to be careful about the posterior aspect where the glands will be located so that one may not mistakenly take it out together with the tumor tissue. Okay. I think that's for the video. Okay, so now this is surgery for apoplex. Like I mentioned, I discussed apoplex before. It's when there's sudden bleeds into the tumor, with in some cases even part of the tumor necrosis in sudden, and then the patient suddenly deteriorates with a sudden loss of vision, sudden impairment in consciousness, and so on and so forth. So what the aim is at apoplex is just to decompress as much as possible. We want to decompress. Luckily, in majority of cases, the tumor would have liquefied due to the effect of the massive bleed into the core of the tumor. So one should just aim at decompressing. And for that reason, because most of the tissues might be matted with some degree of inflammation because of the sudden massive bleed, one needs to be very careful not to be too aggressive, because the chances of CSF leaking tends to be higher in that kind of circumstance. So I mentioned about retracting. There's supposed to be a video playing here. Sorry, it's not playing. Okay, that's it. So the idea, one of the things that we take care to do to achieve complete resection, as we're trying to do here, is to, apart from dissecting carefully along the anatomic planes, layer by layer, okay, we try to, once we get to the tumor, as one is taking out the tumor, it's important, like I mentioned, use your retractors, your curettes, and your probe to retract the diaphragma sella gently in order to be able to access the tumors by the corner. Because it's something that is working by way of gravitational force, this thing just drops down. The ones at the corners, if one is not careful, may become trapped and give one a false impression that the tumor is completely out, only for it to do a post-op scan and discover that it was missed. So to prevent that, we carefully tract the edges of the diaphragma sella. That's the covering, okay, like the dome of the tumor, over the tumor, to make sure that one gets adequate access to the corners, both by the sides as well as anteriorly and then posteriorly. Okay. All right. Okay. This is just to show us one of the huge tumors that we're able to achieve complete resection for. Just the first slide to your left is what it was before the surgery, and of course the MRI is what it was after the surgery. You can see the tumor, as huge as it is here, is completely gone in the same patient after surgery. This was possible because of careful attention to all the details I've discussed in previous slides. Okay, sorry. This lighting is jumping. Okay, now so this slide is just to show us what we do. Sometimes it may be important to take dimensions as part of our plan. In fact, that's one of the things we do. Apart from paying attention to the anatomic planes, one of the key things that we use our scans for, okay, is not just to confirm diagnosis and to know the extent of the tumor, but also to make a surgical plan. And that surgical planning also entails, to a large extent, taking dimensions. We want to know the length and the breadth, and that helps us to know how deep we need to get to be able to take out the tumor. If one is doing the tumor, you get to that level that you've measured, it gives you a guide, and that we're able to also have a rough idea of when we're achieving total tumor resection, whether we're getting the entire tumor removed or not. But by and large, that's like just to show us how we make our plan. This is just to show us, this slide too is just to show us, this is after the surgery, this one after the surgery to my left and before the surgery to the right. This is another patient again in whom we achieved total tumor resection. So the key thing to take note of in pituitary surgery is a transsphenoidal approach rather to pituitary surgery is to follow the landmarks, pay attention to the details, okay, and also to take particular care to make sure that the dissection of the tumor, okay, goes to all the way around, not just the core of the tumor, but get to the corners of the diaphragma sella to make sure that none of the tumor is entrapped. Now, that's for transsphenoidal approach. Sometimes we need to combine it together with transcranial approach, which used to be, the former approach that was more favored before transsphenoidal, started getting more popular. And there may be a few reasons why one may need to do a combined approach. Okay. Commonly we do it in cases where one is unable to achieve complete resection of the tumor through the transperineal route. Like I mentioned, it's a small corridor. Even though one is able to achieve the tumor resection in majority of cases because it's a suckable tumor. Some tumors may not be that easy to access through the nostril. So even with the microscope and with all the technique and skill of the surgeon, that might not be possible. In peculiar situations like that, one may just plan to do a combined approach. And in which case one may have to take a decision on what to do first. Some cases may be better done with the transcranial approach first, and then after that one may go to do the transcranial approach to remove the remnant of the tumor. Otherwise, in majority of cases, the surgeons may want to first of all take out the much they can achieve through the transcranial route, and whatever is left, or whatever they cannot take out through that route, they can take it out through the transcranial route. And then it may be important to do this at intervals, okay, depending on several factors, including the state of the patient, whether the patient is strong enough to undergo, combined approach at the same time, because that's going to be a long surgery. After one approach, you start the other approach. So these are factors to be taken into consideration in carrying out a combined approach. This is an example of a patient in whom we did a combined approach. You can see, if you notice here, this patient, sorry, the cursor is, I'm not sure I don't know if you can see the cursor, but the mouse, where is it? Okay. Okay, where is it? Okay, thank you, yeah. So you can see this is a huge mass tumor extending all the way. In fact, it's like it has already covered the entire sphenoid sinus, and then it's extending above too. The supracellular extension is quite massive. It's really huge. So one can definitely not take this out through the transperineal route only. It's not possible. It's not going to be possible. Same thing with the ones below too. So for cases like this, one may just, one would definitely need to do a combined approach. Reason being that if you notice much of the tumor is extending, if this portion is extending inferiorly, portions of this tumor extending inferiorly will not be accessible at all through the transcranial approach, because like it's growing inwards into the floor of the skull. So you take out the much you can, okay, from above all the way to the area where it gets to the floor of the skull. But for the ones growing a bit inwards, one would need to do the transcranial approach. So these are the cases that qualify for a combined approach. Now, there may be situations of incomplete resection. Despite all the planning and all the skill, sometimes there are some cases that will be incomplete. For instance, the common scenario is when one plans to do everything through the transperineal route. From the beginning of the plan till the time of surgery, that's what it looks like kind of tumor that can be taken out through the transperineal route. Only for the surgeon to get there and discover that either the tumor has become fibrous over time and cannot come out at all, or just a little portion of it comes out, or there's some other problem, some other factors that come into play that wasn't evident at the time of the planning. So those are the cases that end up as a kind of tumor that can end up being completely resected through that transperineal route. For such cases, we normally plan to do a redo as soon as possible. We don't leave it pending for too long. Take the patient back and remove the lesion, remove the tumor remnant. One factor to take into consideration, because it's key here, is possible hemorrhage into the tumor. That's one of the things that could happen too that may lead to incomplete resection, in which case one would have to do the combined approach like I discussed in the previous slide to take care of the tumor properly. Now, these are scans showing some tumors, okay, which turned out not to be the kind of regular, sometimes may turn out not to be the regular kind of tumor tissue that one is expecting. Majority of them tend to be adenoma, like I mentioned, adenomatous tissue, as per the gland itself, having tissue that has begin to form tumor cells. Sometimes it may just turn out to be a meningioma. Okay, meningioma is like a totally different kind of tumor tissue, tumor mass that grows in that same location. It might not be evident at the time of the planning preoperatively, in which case, majority of cases like that, the tumor would often not come out through the transperineal route because they're naturally not suckable. In fact, they're fibrous and hard, unlike the normal pituitary gland tumor that tends to be suckable and easily, removed through the transperinodal route. They tend to be firm, and in fact, the conversion rate is high, like I mentioned. It's almost impossible removing them, if at all, through the transperinodal route. Okay? So this is just a video to show us one such tumor. Okay. Now, I'll talk about the complications quickly. Sorry, our time is really fast spent. I'll round up now so we can take our questions. Just like any other surgery, okay, whether it's an aneurysm surgery like we just discussed in the first presentation, pituitary surgery is not without complications, okay? The important thing is to know which complications to expect, like I'll talk about them very quickly, and then know what to do when any of the complications happen, and of course to make a plan to get whatever needs to be done as quickly as possible. The earlier it is done, the better for the patient. Just take the patient back if need be to do a corrective surgery and correct the problem. So by and large, these are some of the key problems that could happen. Bleeding, like I mentioned, particularly due to the cavernous sinus, the mesh of veins by the sides of the sella turcica where the tumor is located, as well as the carotid artery. Most of the time, we'll plan thoroughly to make sure that this doesn't happen. But you know that in a small percentage of cases, they still happen. If this happens, it needs to be corrected. Then, diabetes insipidus is when the posterior pituitary function is impaired, such that the vasopressin, that's the hormone from the posterior pituitary that controls body fluid homeostasis, is impaired in its secretion for some time. So the body is not able to reabsorb water through the renal tubules, and the patient begins to pour, a lot of water through urine massively. Then, of course, there's the risk of infection happening, being a surgical treatment, that the possibility of infection tracking in through the surgical route to get into the brain and cause meningitis. Then, edema of the brain in that area. Of course, pneumocephalus can happen too, particularly with the transperinodal approach, because it's like tapping out something from beneath the brain. So sometimes, particularly in cases where there's CSF leak, by way of effect of the fluid being replaced by pockets of air, as the fluid is leaking out, in cases of CSF leak, air bubbles may be going in to replace it. And if care is not taken, that may lead to accumulation of air within the brain or within the intracranial cavity, causing pneumocephalus. And of course, hormonal problems can arise. Recurrence of the tumor, even in cases of complete resection. In some cases, there are some tumors that can be that aggressive. Even when it's clear that it was completely resected, they can regrow within a short space of time. And of course, incomplete excision, despite all the planning, could happen. And last but not the least, the ultimate is death. Now, one of the consequences of missing the sphenoid sinus, we're going to talk about it because this is one of the key challenges with this surgery, particularly in the early stages of the learning curve. Is for one to go either too anteriorly and miss the sphenoid, the trajectory to the sphenoid sinus, and end up in the anterocranial fossa, in which case the surgeon goes through the ethmoidal sinuses, and that would often lead to CSF leak. Besides that, the optic nerves are also located in that region too. They could be injured, as well as other intracranial blood vessels at that location. Then posterior, like I mentioned, if one goes too posterior, especially if one goes beyond that Y junction, as I explained in one of the slides, one will just get into the clivus, which is the location where the brainstem is located. That's particularly the pons part of the brainstem, and of course the basilar artery located in front of it. So those are the problems of missing the sphenoid sinus. Like I mentioned, if one is able to carefully observe the anatomic landmarks, that shouldn't happen. Then, for pituitary apoplexy, most of the time, because the tissues tend to be friable, the anatomy is not very clear. The anatomic planes are not clear in majority of cases because of the suddenness and the massiveness of the bleed. And those are the patients that are prone to CSF leak happening, because the more friable the tissues, the more likely it is that that diaphragmal cell, which is like the covering, okay, at the floor of the skull base that prevents CSF from leaking through, could be punctured, even without the surgeon noticing it. And no matter how small the puncture is, it's just like a small bag of pure water being punctured. No matter how tiny that puncture is, something would leak through it. That could happen, in which case the patient may need to go back for a repair. Okay, so I think it's not moving. Okay, so this video is playing. Sorry, I won't be able to play this video for long because of time. Let's move on. So the key thing to do is to have a plan, like I mentioned, for every mishap that happens. Okay, most of those things I mentioned, those are the key problems that could come up from this surgery. But the thing about surgical practice is to have a plan for every possibility. All those things are possible. Even in the best of hands, they've happened. Okay, so have a backup plan how to deal with each of the problems, and plan carefully on how to deal with each of them. I need to talk about CSF repair because it's something we've encountered in our practice, and we've learned a lot, from that kind of problem. And even with the best of care, particularly in apoplexy, like I mentioned, there could be a puncture of the diaphragm cell and the CSF could leak. Okay, the video it's not playing. Okay, so this is just to show us one of the cases that we did. Is a very interesting case. We had to take this patient. We did all the other non-operative measures that we normally do to make this thing to stop, the CSF leakage to stop. It didn't stop. In fact, apart from the CSF leakage, the accumulation of air also happened. So we had to take her back to theater. And the key thing to note here in this video that we did is that we did a multi-layered repair. It's like a puncture for something leaking. So the idea is that if to reduce the likelihood to the barest minimum of that leakage occurring again, we'll do that repair in multiple layers, not just one layer. You repair the first layer, you do the second layer, and so on and so forth. And one of the things that we utilize here, we use the tissue glue. We can use harvested fats. We can use harvested fascia. So you can see this is probably I should just allow the video play till the end. And even gel foam. And of course, it didn't leak. But the key thing to take note of here, the key factor that I'm trying to demonstrate at this point is that CSF repair must be multi-layered for it to be thoroughly done, and for one to ensure that that possibility of having a re-leak is zero, completely, zero. One needs to make sure that it's carefully done. And then very important too, that it must be done under good magnification. Idea being to know where it's leaking from. You must first of all identify the point of leakage, clearly delineate that point of leakage before you start the repair. It must be done under good magnification with excellent lighting too, for it to be properly done. Sorry, because of time. I think that's the end of the repair. So the other thing I need to talk about is vascular injury. This is one of probably the worst complication of all the complications, because if it happens, particularly if it's carotid artery, the likelihood of recovery is probably less than 1%. It's possible, almost impossible for our patient to recover. So it's extremely important that we will thoroughly plan to prevent it. But even with the best of plans and expertise and technical approach, it still happens. Now, to prevent this in our practice here at Wilson Lagoon Hospitals, one of the things we have employed, and it has been very helpful, is to utilize intraoperative Doppler ultrasound scan. It helps us to identify where the tumor, where the vessel is located, particularly for tumors that are already encasing blood vessels. So as you are resecting the tumor, you don't want to go and suddenly burst a blood vessel and then enter into disaster. So that's the Doppler ultrasound being utilized to identify the. Sorry, my slide is not moving again. Okay. Yeah. So complication avoidance, in a nutshell, please, for those of us who are surgeons, practicing this kind of, who intend to practice this kind of approach, it's very important to study the anatomy. Preoperative planning, in fact, is the basis, the backbone of avoiding complication, okay, in transfemoral surgery, and get thoroughly familiar with the kind of pneumatization that the patient's sphenoid sinus is. There are about 3 different kinds of sphenoid sinus pneumatizations. So be very familiar with it. All this is still part of the planning. And of course, at the time of the surgery, taking care to follow the anatomic planes layer by layer so that things don't get muddled up. Because the clearer the anatomy, the better. The better for the surgeon, the better for the patient, and the faster the surgery. So just follow everything step by step. And of course, very important, after removing the tumor, like I mentioned, make sure you probe the corners to make sure that any tumor remnants are removed. And like I mentioned, planning. So even that planning may still need to continue. In case something happens post-operatively, it's still all about planning. So this slide is just to show us how we take care to plan, okay, taking multiple dimensions, okay, to delineate a particular spot, where the target is, because we don't have neural navigation. This is one of the things that neural navigation can do, but we discovered that with careful planning, taking careful dimensions, you can still get the same effect too that neural navigation could give one. This slide is just to show us how useful, the surgery can be in helping patients who are already having compromised vision from the mass effect of the tumor. This patient is a patient that was almost going blind, as shown in the test findings from the preoperative neuroophthalmic review. The ophthalmologist son confirmed that through this patient was already going blind. You can see the part of almost half of the eye fields on each side, both the left eye and the right eye is completely gone, those dark areas on top. But if you see below, the same patient after surgery, within weeks, in fact, days to weeks, everything cleared and is completely okay again. Probably a little bit of a spot there, as you can see in the pictures below. But the bottom line is that if this surgery is carefully done, the clinical outcome is good. Improved vision, improved libido, and improved fertility, because most of the problems, the hormonal problems, they tend to resolve almost immediately. Irregular periods, galactorrhea from the breast, and so on and so forth. And of course, resolution of headaches. Now, for the difficult cases, occasionally we have difficult cases that may not be amenable to surgery. For cases like that, you don't want to do surgery, because surgery is like asking for problem. Particularly the hard, extensive tumors, as you can see, these are some of them. Luckily, they are not common, both in our practice and in the literature, but occasionally they still do come. And when we see them, the ideal thing to do, like I mentioned here, is just to take a biopsy. The reason for biopsy is to get a histologic confirmation of the kind of tumor it is, because that's what the oncologist who will actually offer the treatment, what we call radiotherapy, will use to treat the patient. Radiotherapy is a form of treatment that shrinks, like a kind of treatment that shrinks the tumor, okay? Since surgery is not a possibility in majority of such cases, the idea is to get that histologic confirmation, because it's a standard practice that oncologists, they will not offer the treatment unless you get the biopsy to confirm. And so that's the standard practice for such cases. Luckily, like I said, they're not very common in practice. Then we need to also know that pituitary tumor, just like many other lesions in the body, have differentials as per what else such tumors could be. Majority of cases that are normally straightforward when we see them on scan. However, there are some of them there are some tumors that can happen in that location that have a couple of characteristics that help us delineate them and know that this one cannot be a straightforward pituitary adenoma or pituitary tumor, it's something else. One of them is what we refer to as a meningioma, a cellular meningioma. So, I don't know if it discusses, but to the left of the screen, the left side of the screen, you can see this tumor lying on top of the region of cellular toxica. If you notice carefully, is blending into the dura, giving what you call a dural tail. So this is a very classical radiologic finding in meningiomas, wherever they are located. So once we see this, we know that this can definitely not be a pituitary tumor. And it's important to pay attention to the differentials, what else the tumor could be, because the treatment approach and surgical access to each tumor varies. What one would do for pituitary tumor, for instance, one can you can see only very few surgeons who would want to attempt this kind of thing to the transphenodal route. So to avoid such colossal errors happening, doing the wrong surgery for the wrong kind of tumor, it's important to consider differentials. Something else that can happen in this region, or that can occur in this region that may mimic pituitary adenoma, is craniopharyngioma, which I'm not sure, I don't have it here, but this is mainly meningioma. Okay, so by and large, we've discussed aneurysms and then pituitary tumors. I believe some of us would have questions. I would like to take any questions, any clarifications. Thank you very much.
at this juncture, we'll be expecting your questions. So if you have questions, you can ask questions, or if you can chat, we'll take it up from there. Thank you.
Okay, sir, yeah. Stop sharing.
Questions, you can chat on the chat box.
Thank you.
Just raise up your hand and ask your questions. Dr. Onyia and Dr. Ojo are here to take your questions. Thank you.
Keep it charged. Okay. Thank you. Let me disconnect this for you.
We are still open to take your questions.
Ben, sorry. Can I just pull? I can pull it down. Okay. And some laptops will tell you. Thank you. Okay. Thank you, sir. I've already copied it. Thank you.
Okay, thank you very much. I'm Dr. Gallo. I want to use this time to thank our presenters, Dr. Ojo, Dr. Tayo Ojo, and Dr. Onyia for the comprehensive presentation that we just had this morning towards afternoon. I also want to thank everyone that listened in on the call and everyone that has been present here physically. We appreciate everyone on behalf of the Lagoon Hospitals. I believe there are no questions now, but if questions come up later, please you can send in your questions. How do they send in questions? On the same call? Yeah. Okay. So we can look at them later and then that will be addressed by our neurosurgeons much later. Once again, thank you for listening in. Okay, till another time.
Thank you. The interruptions.
We're done?
Yeah. Because I noticed that there are more people who as time was going on. Exactly. So, before you do so, the scan, did we discuss it? And then I forgot to mention, there was a patient that we discussed before. They just gave approval, so I'll schedule it for next week. Okay, my brother, thanks for the support. Thank you.